So it is very, very helpful, this scanning, epi-aortic scanning of the aorta. I don't have just a couple of pictures from us. We also found a couple of cases in our experience. We haven't summarized the results, but this is we find normal aorta, and then we feel pretty safe. Then this is another paper published in the European Journal in 2006. I just took out this very, very good article. I saw early strokes in patients who had scan of the aorta and people who didn't have scan here in this one. So you see that by using scan, they reduced the stroke rate from you see 4% to less than 2%. This was not a randomized study, so I think that Dr. Kemmler's study will be very important, but the indications and the logic tells us that epi-aortic scanning will be very, very useful. And then, of course, when you have finished your grafts, I always ask myself, how did I succeed? With coronary bypass, to do that anastomosis, in my opinion, is the most difficult thing in the way we do in cardiac surgery. At least the finest, the most delicate procedure we do. And then not to check whether it is patent or not. I think that it is, just to say that I think that I always do good grafts. This is not true. Of course, I do myself more or less everything on the beating heart. I will not show this film in the interest of time. It was just a clip of a beating heart surgery. But what is occlusion rate in coronary bypass surgery? I think that some generally accepted numbers, immediately after surgery, 3 to 5% at least of the grafts are occluded. And after 3 months, 5 to 10%, after 1 year, maybe 10 to 15%. So this is not insignificant. And of course, the question about off-pump, which we started in 1990s to push that up to almost close to 100% of all the cases. Randomized study comparison of off-pump and on-pump multi-vessel coronary bypass by Kahn and Pepper. They show that there was lower patency in off-pump. This has been quoted a lot, this study. When you look at the meta-analysis talking about off-pump, here is favors on-pump here, favors off-pump here. So you see that in most of the studies, really the off-pump cases have slightly lower patency rates than on-pump. And the problem with some of these studies is that they didn't use any graft verification. They didn't check the grafts. And I think anybody who's doing both on and off pump can agree that off pump is a little bit more difficult. So you're probably going to have a little bit higher failure rate. But you're going to have failure rate in on pump as well, but also in off pump a little bit higher. So that means it's even stronger reason to check in those cases, but also in on pump cases. Well, this is just a picture of my hospital in the United States, where we did this study. We found that 3.7% of grafts needed revision, and all except for 3 grafts improved after revision. So that means that if you find a graft that doesn't have a flow, or has low flow, or has high PA that Dr. Wolpoth talked about, you almost always you can fix it. There's always, if you use the correct criteria, there is almost always something wrong, and then you got to fix it, if it's possible. There are occasions when you cannot fix it. Maybe you grafted a very bad vessel, but it's the exception rather than the rule. So this was 3.7%. We had that earlier case. We had even higher. It depends, of course, on experience, on what type of vessels you do, etc. But I think the vessels are getting gradually worse for all of us. So when you have this type of pattern, you have 17 milliliter, it's not so high, but you have low PI, you have this type of flow curve, you know that your graft is okay. And I must say that myself, I basically refuse to do coronary bypass in my practice if this type of technology is not available. I will jump over. So just one further use of TTFM that we have observed that I think is quite interesting. It also has impact on the post-operative care. And what we did a small study, we did this actually in Bosnia. This was a randomized study, only 20 patients. We looked at two groups. One group, all patients for off pump in our experience get aspirin pre-op, and then we randomized to whether just continue aspirin or we gave clopidogrel post-operatively, starting immediately after surgery if there was no bleeding. We checked the graft patency by TTFM and then with angiography after 3 months. And what we found was that, just a couple of slides, I will not go through everything, but if occluded grafts had lower flow than open grafts, and the PI was higher in occluded grafts than in open grafts. But it was not the real cutoff. But what we found also that the predictors of patency was high flow and presence of clopidogrel. So if you have high flow and everything is, you have very high flow, you have low PI, all these parameters from TTFM are good, then maybe you don't have to give clopidogrel. But if you have a graft that you cannot improve, it has a low flow, and then you better start Plavix right away after surgery to keep that patent. So I think that as we learn more, the value that we have of this type of technology is quite significant. But in my opinion, epi-aortic scanning should become routine in coronary surgery involving manipulation of the ascending aorta. And we can also use epicardial ultrasound to locate intramyocardial vessels or locate the unknown lesions, find a suitable place for grafting. And I think that graft verification should be mandatory in all coronary bypass operations. Thank you very much.